Hi, I'm Will McKane, and I'm a kidney physician at the Northern, and I've been in Sheffield for quite a long time. I kind of felt I might recognise a few faces, but the only face I recognised seems to have gone, which tells me something about what he thought about what I was going to say. So hopefully myself and my colleague Shareen, who, you say hello.
I'm a bit shorter. Hi, I'm Shareen Siddiqi. I'm one of the nephrologists.
I think the message we're going to try and give is hopefully a relatively straightforward one. We were going to try and do some interactive cases. We're still going to try and do it, but the acoustic of the room and the lack of microphones might make it a little bit difficult, but we're going to do our best. And now I've got to work out how to use this slide advancer. Oh, and my slides have been tangoed. I don't know if anyone else is coping with the orangeness, but my slides have been tangoed. I don't have any disclosure. So this is the kind of overview of the talk. I want to talk a little bit about the epidemiology of CKD, and probably a lot of you will have heard talks about epidemiology of CKD, especially when EGFR came out sort of 15 years ago, and it probably hasn't changed a massive amount. A little bit about healthcare economics. And then I want to talk about what's really new from the latest version of the NICE CKD guidance, and in particular the kidney failure risk equation, and that is the sort of main message. And then we're going to try and illustrate this with some cases, and I promise you the cases are not, who is that idiot nephrologist talking to us about some obscure disease of the distal tubule late in the afternoon when we've been taught it all afternoon. They're pretty straightforward cases to illustrate some of the points we're making. So that's what I'm going to try and say. So a really important change in the NICE CKD guidance is that the key criterion for referring people for a nephrology assessment has been this equation, which is now reasonably well validated in UK populations, although it came from North American populations, that attempts to predict the risk that someone will end up with advanced kidney failure or kidney dialysis. And one of the problems is that to use the KFRE, we've got to measure urinary albuminuria. And we're not always very good at doing that. And that is not directed as a criticism. We're not very good at doing it in secondary care always as well. So that's just a reality that we find it much easier in general to get blood from patients than we do to get urine from patients. And that's just a fact that I accept. But I still want to challenge it, okay? And we need a kind of system approach to do that. And various ICBs around the country are trying to take a more system-based approach. So this is the classification of CKD. I don't want to spend too much time on that because a lot of you will have seen this kind of graph before. And you won't get letters from many nephrologists sort of classifying people as G3B A2 because partly what you'll know is that these patients oscillate between these different stages quite a lot, don't they? So someone's measure of albuminuria and GFR 1 month is a little bit different from their measure in other months. But the color coding does just give you this feel that a low GFR is bad, makes sense, and a lot of proteinuria is bad. And actually that lot of proteinuria is not necessarily that much. So, and CKD is common, and the kind of GFR explosion and all the education that was done around that, I think has probably got that message across, that an awful lot of the UK population have chronic kidney disease, and that most of that is relatively early chronic kidney disease, and not very much of it is advanced chronic kidney disease. And that there is a male-female split here. And that may be to do with the way we define chronic kidney disease rather than a true disease split. And I suspect most people in this room are also incredibly familiar with the fact that the great majority of these patients with CKD have CKD in the context of other diseases, often in the context of 2 or 3 other diseases. Diabetes obviously being top of that list, heart failure being on that list, hypertension being on that list, some rheumatological diseases, obesity being on that list. So that is important, I think, in terms of how we should approach CKD, because we're not really approaching it as a disease in isolation. And an awful lot of the cardioprotective treatments are renoprotective treatments. And again, you guys know that. So if I were to try, and there's an awful lot of these patients, but most of them won't end up needing dialysis. So how can I pick out the people that might need dialysis? And the answer is pretty straightforward. How well their blood pressure is controlled, how much protein they've got in the urine, how low their eGFR is, and how old they are. And with the great majority of diseases, the older you are, the more likely you are to have a bad outcome, as we know. But actually, in CKD, because it's partly a disease of aging, in a way, we're typically more worried about the patients with a degree of chronic kidney disease at a younger age, because they've got a lot of years ahead of them, and they are the ones that are more likely to end up with advanced chronic kidney disease. So it's slightly inverted from what we see in many chronic diseases. Now, I don't want to talk about dialysis, but I'm trying to give you a feel for the scale of the problem. So we have got, in the UK, this is a couple of years out of date, this slide, about 70,000 patients on renal replacement therapy. That is a big number of patients. And the curve is doing what the curve in a lot of chronic diseases is doing, not just chronic kidney disease. There's more and more and more of it. But one thing that does set end-stage renal disease treatment apart is it's phenomenally expensive. This is an NHS England slide. I think it's a bit of an underestimate, actually. For example, dialysis transport down at the bottom, which you may be able to see, the NHS improvement estimate was that dialysis transport costs £150 million a year. That's just to take people for dialysis. So they're very big sums of money. And there's a specific reason I'm putting the money slide up here, which is that there is going to be a change in the way dialysis is commissioned. Dialysis is going to be devolved. It will be devolved to ICBs, and therefore ICB budgets will start seeing the pain of growing dialysis populations. And, I've done a lot of work with NHSE and NHSI, and, this is a very deliberate strategy. This is a very deliberate strategy to make people working in primary care, looking after population health, think about what can we do about earlier phases of CKD, because we're now faced with the bill for late stages of CKD. Now, devolved commissioning was supposed to happen last April. It's now supposed to happen next April. I think it might be yet another April, to be honest with you, because that's how NHS England work. But it will happen eventually, that the pain of the growing dialysis bill will come to ICBs and will clearly be competing for funds that could be going to other things. And this is a really old slide. On the left, that's the original Mr. Fit study showing the relationship between cholesterol and dying. And that's again American data. On the other side, it's Kaiser Permanente data showing the relationship between how much CKD you have and dying. It's just an associative relationship. But probably no one can read it. The scale on this one is 10 times. So the relationship between CKD and death is incredibly strong. And the relationship between how much protein you've got in your urine, and it's an American slide, this is NHANES data, so you can ignore some of the unit. Actually, the units there are okay. It's the creatinine units that we can't cope with. There's a very strong rate of progression of chronic kidney disease when you've got more protein in the urine. And there's also, again, NHANES data, a very strong relationship between how much protein in your urine is and your cardiovascular death rate. So it's a marker. Proteinuria is a marker of cardiovascular risk to a large degree. And, people have looked at incorporating it into QRISK-3, and the main reason they haven't incorporated it into QRISK-3 is it isn't measured often enough to kind of be relevant to most practices. So what do non-specialists do? I'm not going to read that out, but I think what I want to talk about particularly is assessing the risk of progression and deciding whom to refer. So this is looking at, this is a national CKD audit on the right here, and it's looking at how likely you are to have had an eGFR measured. So these are all primary care, these are based on primary care data sets in the context of these diseases. So you can see if you've got diabetes, we're pretty good at measuring kidney function, and it kind of gets progressively worse. Particularly when you're getting into diseases associated with chronic kidney disease and drugs associated with chronic kidney disease, we're much less likely to have checked an eGFR. So how do we screen? So traditionally we've sort of screened by measuring the EGFR. We've may or may not have done urinalysis. I have to say the number of referrals that we receive that have a urinalysis result in them is very, very small. That's not to say it's not been done, but it's not information that is readily shared with us in referrals. An albumin-creatinine ratio, and I don't want to get into a debate about albumin versus protein-creatinine ratios, but generally NICE favour albumin-creatinine ratios, and that is the only measure you can put into the KFRE. So I think, and actually it's been more of a secondary care phenomenon than that. I think on the whole in primary care you have been measuring albumin-creatinine ratios. And now the big change is that we're encouraged to use the kidney failure risk equation. Now, we get a lot of referrals of people with elevated ACRs with catheters in, or not with urinary tract infection, but with sterile pyuria, or with ileal conduits. The urine ACR is not really a valid measure in those patients, and so that's just worth bearing in mind. So what NICE now says is that you should refer or seek advice from a nephrologist in a patient whose kidney failure risk equation at 5 years is greater than 5%. That's a pretty low threshold, actually. So a 1 in 20 chance of ending up in dialysis in the next 5 years, and you should be seeing a nephrologist. And that's the big change, and that's the kind of top of the referral criteria. There clearly, many of the other criteria remain. I don't want to cloud the message by going back through those, but that's become the key criteria. The number of referrals we're getting 2 years after that guidance with a KFRE is very, very small, and there are probably all sorts of reasons for that, but a key one is that the urine ACR either hasn't been measured or has been measured, but it's not been measured contemporaneously with the EGFR, which is a challenge. The other things in NICE that are relevant is they've chosen to remove the race coefficient from calculating EGFR, and the role of SGLTIs, which many of you will know more about than I do, has been greatly increased in chronic kidney disease. So this equation is only a tool, like all these equations. But it's trying to use the EGFR, the ACR, the age, and the gender to estimate kidney failure or dialysis risk. I'm not going to show you the equation, it's long and complicated. It doesn't count for the competing risk of death, so it doesn't really work as well in the very elderly and frail. So if you have someone with advanced heart failure, probably in the last year of life, whose KFRE is 6%, it may also almost be irrelevant because their risk of death from their heart failure in the next year is pretty high, and their chance of getting to 5 years are pretty slim. So I'm not saying I wouldn't refer those patients, but just bear in mind this equation at the minute doesn't take into the fact that many of these people are at high risk of dying in the next 5 years as well. So it is a weakness of the equation at the minute. It only works if the EGFR is less than 60. And I should also have said it only works where there is some proteinuria. If you get an ACR result that cannot be calculated because there's no protein in the urine, the equation can't cope with it. But I'll tell you how we're going to try and approach that. And it's a static equation, so you do lose. So it's only telling you about that moment in time. It's not telling you about the delta, the progression of EGFR that has kind of become the bread and butter of how we identify people at risk of progression on the whole. And this is data from the National CKD audit, and it's just showing the relationship between age and CKD, which kind of just will be the reality of your everyday working lives anyway. And it's also showing the proportion of CKD that is coded and the proportion of CKD that is uncoded in primary care. It was in England and Wales, the National CKD audit. So I was interested to hear about the Arden searches, which that kind of strategy is clearly relevant to CKD, but that's a talk for another day. This is just to illustrate my point about the competing risk of death. So this is US data. I think it's from Kaiser Permanente again. And even if you look at patients with CKD4, they're more likely to die than to ever end up on dialysis, sadly. And that tells you about the constituency, really, doesn't it? So these are screenshots from there's a web-based app and a mobile phone-based app for calculating KFRE. It is sponsored by pharma, I am nothing to do with it. But if you use the right one that has kidneyfailurerisk.co.uk rather than .com, because the equation is specific to the UK, and you put in the 4 variables, you will get an answer. And you can tell what a terrible artist I am. That's my attempt to draw a heart around the urine. So nephrologists love it if somebody's measured the ACR. And this is how good we are at ACR testing. So this is from the National CKD audit again. And you see we were quite good at measuring EGFR. And this just illustrates that we're not that good at measuring proteinuria. And that is, I think, in the last year in that study. And that audit was all pre-COVID. And clearly the pandemic did affect our ability to test this kind of thing. So if you take a patient of 73 with CKD4 and EGFR 28, but not much protein in the urine, you find that their KFRE is not that high. I'm actually surprised it came out at 4.7 there. So that is approaching the threshold for referral, but not at the threshold for referral. If I had put 0.2 milligrams per millimole in there, the KFRE would have come out at about 1%. So there's an awful lot of people with quite advanced CKD who have no proteinuria, who are not at risk of progression. And the other thing it helps, I think, is with counselling patients. Well, yes, you must experience this. Patient says, I've got CKD4, it's terrible. But actually saying, yes, you've got CKD4, but your chances of ending up needing kidney dialysis treatment are pretty small. And for some of them, it is down in the sort of 1% or less than 1%. And this is just another one. So this is a younger patient, EGFR 40, but actually with a bit more protein in the urine, and you can see it generates a KFRE of 7%, which would then meet the threshold for referral. Now, I think a lot of people sitting around are probably saying, yeah, well, but to be honest, if I had a 40-year-old with an EGFR of 40, I probably would refer them anyway. And that's fine. I think that's right. It's just a tool to help identify, and it's as much the people that you maybe wouldn't refer, because their KFRE is incredibly low, as to identify the people you would refer. Now, the next question is how to calculate it. And there are various ways. I mean, I don't know, there are some practices nationally that are embedding it in their primary care EHRs. Is anyone in Sheffield doing that? I think it's great. I think there are issues with the fact that when you don't go for a coordinated approach of integrating these equations, and I know this from a lot of work in the AKI algorithm, and I'm not going to talk to you about AKI, is that actually it goes wrong, and also the algorithm changes and people get it, so it's quite difficult. So absolutely no problem with implementing it in primary care EHRs, but I think on the whole, nationally, there's a general feeling that implementing it in the laboratory information systems and in the order columns, now you request the test, will have greater strengths. But I don't think it really matters how you do it. It's how it works for your practice, I suspect. So the Sheffield lab are, I think, the first large laboratory to have integrated it into their requesting and reporting. It is only, this screenshot is a bit of a cheat because it's only just it's been on the secondary care requesting for about 2 or 3 months. And then we realized it wasn't actually available. We thought it was available for primary care testing, and it is now, but it wasn't at the time. It is not in any of the sort of order sets yet. And I know that, I can't remember who it was, someone from one of the sort of a GP leader had said it would be much better to get it into some of the chronic disease monitoring order sets. So I think that work is happening. But if you want to request a KFRE, then the thing to tick is CKD monitoring. And if you tick CKD monitoring, it will generate a request for a urine ACR and an EGFR at the same time. And the laboratory will then do the calculation for you, and the calculation will come through in the result. Okay? We've relaxed it a little bit. They're supposed to be on the same date, if you look at the original publications. If they're within 7 days, it will report a KFRE. If they're within 8 days, you won't get a KFRE, And you then, I guess that's where, if you're reporting it within your own EHR and you've given yourself a little bit more latitude than 7 days, that there may be some advantages. Although you are straying from the evidence base. Although we're probably already straying from the evidence base because we're not using the creatinine assay for which the whole thing was validated. So, it's none of these things are perfect. So you can still calculate it yourself by whatever means if you miss that 7-day window. And also, it totally depends on patients, us having systems to gather urine collections, spot urines, and for patients engaging with the process of. So there's quite a lot of patient education would need to go on, because I just know from looking at primary care results, it's dead easy for me, because I see someone in a clinic and I send them for blood and a urine and it all happens at the same time. But I know that isn't the reality in primary care. So I suspect there's a bit of a culture change would be required to reliably get these around the same day. And that's partly why we're speaking to you today. And maybe this is from the Northern Alliance in Salford, and they've done a lot of case finding work. I'm not going to talk to you about case finding, and they're developing their CKD dashboards to give you a much better feel for, okay, who is in a. Tangri was the academic that developed KFRE, so they're talking about KFRE there. Who are the high-risk patients? It's clicked on low risk at the minute, but if you clicked on high risk, which of these are on the appropriate secondary prevention measures? So I think that's a kind of vision of the future, and I don't think that kind of thing is that difficult to implement, actually. But there hasn't been a lot of energy to do CKD dashboards in South Yorkshire yet, but maybe that's because we've not been talking to the right people. So my take-home messages are one that's probably already familiar to with you, which is that it's a very common disease, but not very many people end up on dialysis or with a kidney transplant. If you're measuring EGFR, consider measuring urine ACR at the same time. You clearly wouldn't do it every time. It would be over the top to measure urine ACRs maybe as often as we do. But I think that's the message. Whenever you think about it, if it's an annual review, okay, we're going to measure urine ACR at the same time. And we tried to make that a little bit easier by implementing it within the LIMS and the ICE. And I think once that gets into the chronic disease order sets, that will probably help more. Refer primarily on KFRE. But we're happy to see advice and guidance referrals or referrals, of which there's virtually no distinction now actually with ERS on anyone. It doesn't worry us. And we clearly don't want to avoid the 22-year-old whose GFR is 92 but who has blood and protein in the urine. But I don't actually think those are the referrals that are a problem. It's much more about the elderly, frail, multi-morbid patient helping in primary care judge how likely is this person to end up in dialysis and how likely is a secondary care physician to add to their chronic disease care. So I know we said no questions, but I don't mind taking some questions if people want to shout.
Given the fluctuations, as you said, in the ACR and the creatinine, so getting somebody that comes in at 5.1% and then you check it again and it's 4.8. So just have you got any sort of practical tips for, how often we need to do it if it's on that borderline figure? Or is it just common sense?
I think it's just common sense. I think, I could bore you with some of the other quality assurance stuff around KFRE, which I deliberately haven't. But if you send exactly the same urine and blood sample to a laboratory in Leeds and you sent it to a laboratory in Sheffield, you probably would get a slightly different result, actually. And there is the first EQA scheme is being set up by NECOS to try and look at that. So I think absolutely, if you get one of 4.8, but actually it's someone where you feel clinically, yeah, maybe they're a bit younger, maybe there isn't an obvious cause for their chronic kidney disease, I wouldn't want that to put you off referring them. I think it's more to help with the ones where they've got CKD4 and actually you do their KFRE and it's 1%. And I perhaps should have illustrated that. Because it's and they're already under the heart failure team, and you're already doing what you can for their diabetes care. It is pretty unlikely that we would add much to their care in those patients, even though their GFR is 21.
have a second question. So, as you rightly say, a lot of these people are going to die of something else, not their kidneys. So, is there anything you've got, a sort of practical website or any sort of ideas where you can look at? I mean, obviously we can use our common sense, and we know our patients, and like you say, a lot of them have got 3 other conditions. So, is there anything you could guide us where, okay, it comes up at over 5%, but because they've got 3 other things, you don't. What I'm saying is, do we just use our sense, or again, is there anything where you would be guided by, say, they've got an existing heart failure diagnosis, and you know the prognosis that is likely to be worse? You know, is there anything where we can say we can stop that referral from going ahead because we know that the likelihood is they're going to die of something else, not the kidneys?
There's quite a lot of resource now on the NHS Futures page under a thing called the Renal Services Transformation Programme. The National Clinical Director happens to be a CKD expert for renal disease, happens to be a CKD expert. She's based in Salford. So there's quite a lot of resource on the Renal Services Transformation Programme pages of NHS Futures. But I don't know how many of you access NHS Futures. It isn't actually that easy to access. But I think if there's doubt, I don't think we've got a problem with an advice and guidance request to ERS. You know, that is becoming. I'm sure this is true of every specialty in the hospital, but certainly every medical specialty. That is becoming a larger and larger part of dealing with referrals. So you know, I'm not trying to put people off referring, but I guess what I am trying to put off is dragging the 83-year-old with 4 comorbidities who finds the whole experience of coming to a secondary care clinic awful, and where we don't then add it. We make them sit around for 3 hours and then we don't add anything to their care. And then also they see someone less experienced who brings them back for a follow-up, and then another follow-up. You know, I don't think that's good medicine, and I suspect none of you would think that's good medicine. But I think if there's doubt, putting in an advice and guidance referral is a perfectly reasonable thing to do, because it isn't easy, this stuff. Yes, thanks.
I work with a company. We're developing KFRE and a number of other calculators for deployment in either System 1 and the other new entrants that are coming next year.
Yeah.
Actually on sort of a national level.
Yes.
And I'm just sort of toying with the idea of where surveillance and sort of a proactive, if the data's there, do we use it, how do we reflect on it? How useful would that be for a clinician in the city? You've sort of answered a lot of that question about how it might give context, but do you think that would be a good approach?
Do you mean actual case, so doing sort of coming back to case finding and saying these are the patients who are at risk of CKD but haven't been coded for CKD, and these are the patients with CKD who have not had a KFRE in the last 3 years, that sort of stuff?
All of that, but also the KFRE is done automatically if the data's relevant and there, and the timeframes are appropriate. So,
yeah.
But do you feel, you mentioned that you feel that probably ought to be a centralised lab requested proactive process, but do you think there might be a role for that?
No, I do, and you probably are familiar with Rupert Major, who is he's a Leicester physician. He's the person that's led on this in the United Kingdom, and he felt very strongly, yes, getting it into primary care EHRs was the right approach. The problem is we've had our fingers burnt with the AKI algorithm, because we've discovered that the AKI algorithm gets put in differently, even within laboratory information systems, gets put in differently. And we also felt it would be better to integrate the requesting into to have a link between requesting and reporting. I know it doesn't solve the problem of actually getting the urine, which is probably the most difficult bit. But no, I don't have any problem with it being in EHRs and being used as a surveillance search type tool for case finding and case management. But overall, I think it's probably safest deployed within the LIMS. So you've got energy for cases, but they're not. I promise you, they're not difficult care. I'm going to hand over to my colleague Shareen. I've been wittering on for too long.
That one.
That one.
I presume you can hear me, but I'm not shouting. Right. So I'm going to first point out I'm slightly alarmed when I looked up GP consultations. Why are you on fire came up. So the idea is this is interactive, so feel free to jump in. It's not that long, so there's time for questions if you want. So Will's kind of mentioned, we didn't plan this, sort of the typical patient that you'll often get. So you've got an 85-year-old male, you can all read, but in case you're losing the will to read, he's got obstructive neuropathy, hypertension, LVSD, it's given an ejection fraction of 35%, arthritis, and he's frail. And he's got an eGFR of 26. So if this has worked, oh no, I planned to do it, but sort of it came up bit by bit. And he had an AKI in 2015, so his eGFR of 59 dropped acutely because he had an AKI, and it didn't really recover. He had a TURP, but he's got obstructive nephropathy, and his eGFR is 28. He's got decent blood pressure. He's anemic, but that's where we'd expect his hemoglobin to be at this level of renal function. You don't need to read all those. He's on all the drugs you'd expect him to be on, a beta blocker, an ACE inhibitor, alpha blocker for his prostate, aspirin, and cocodamol at a level that doesn't offend us. And he's not on an ACE non-steroidal. So what do you want to do next when you get him into your practice? And I guess Will's probably given quite a good cue as to what the next test is. But I think there's a wandering microphone somewhere where you can just shout out.
Yeah.
It's fantastic. So a urine dip and an ACR if there's protein on the dip. Having said that, actually, I tend to do an ACR even if it's negative, so I can put it in the equation if I need to. And realistically, if you don't do a urine dip, if you don't do an ACR, you're not going to be able to put it in that equation. So his ACR is 1.2 milligrams per millimole. I put, would your ultrasound scan his renal tract? I'm going to do a disclaimer at this point. You don't need to do a scan of the renal tract to refer to us. We tend to scan everybody, which could be argued with quite hard, but he's a man in his 80s who's had prostate repair before, so he's had an ultrasound of his renal tract. He's got 2 slightly small kidneys, and they're as expected. So should you refer? You want to know his KFRE, and on him, and these are correct figures, I put them in, his 5-year KFRE is 3.1%. So as he stands, he doesn't need referring. He's more likely to die with rather than from kidney disease. So I also run the conservative care clinic for patients with an eGFR below 15 who aren't having dialysis, and the majority of my patients will die with rather than from kidney disease. I've put a bit of a caveat here, and it's a bit of what Will said about this is KFRE is to kind of encourage you, who do you need to refer, but not a barrier. So if this chap's got a hemoglobin that's low, there's no other cause, and you think, actually, is this renal anemia? It doesn't matter what his KFRE is. Actually, yes, we can help and support with that. And if you're not sure of what the guidelines are, then just refer to us, and we can say, he doesn't need to see us, yes, he does. Or if he doesn't want to come up for IV iron, how can we manage him? The next case is a bit younger. You've got a 36-year-old woman with type 2 diabetes. She's got complications. She's had background retinopathy previously, and now she's had a laser in her right eye. Her eGFR was above 90 pre-COVID, but you've been monitoring it gradually after the sort of blip in the middle, and that's come down. Her HbA1c is not catastrophic, but it's been much higher. I didn't mention the hypertension. She's also got hypertension, and she's on nothing that would particularly surprise you. So you want to do an ACR. She's got an ACR of 257. Now, in reality, for this lady, she's got no blood. Would you scan a renal tract? You probably wouldn't, and you don't need to. I put it in there so nobody asked me if she got obstruction. Do you refer? So you would, but also for this lady, actually, even if her KRF was never going to be low, but she's young with significant kidney disease and a lot of proteinuria, so you're going to anyway. The only other thing about this lady, if I had massaged her figures hugely to get her KFRE 5 years down to below 5%, she's still got a huge drop in her renal function. She's young. Her eGFR has dropped by sort of 30 points in 4 years. So if that trajectory of decline continues, actually we're in a problem. I can't see any way. It is a static equation. So if you just do it on one value, the computer won't recognize what it used to be like. I can keep going. I talk really fast. I'm aware it's the end of the day, so you probably want me to talk fast. But if you have any questions, jump in as we go along. So case 3 is a 74-year-old woman. She's hypertensive and she's a smoker. And a year ago, her eGFR was 55, and now it's 45. And I've put the creatinine just to show actually sometimes not a big jump in creatinine does change the eGFR significantly. She's not very much excited either. Go on. So she's got blood and protein. Her MSU is negative, and she's got an ACR of 10. So a 5-year KFRE is 1%. And I guess this is just to say, this lady's got hematoproteinuria, so actually she should be referred. When you refer her, so as Will said, the Sheffield referral system now is a combined advice and guidance and referral system. So when you refer her into it, we may say, we don't need to see her, and actually you can do X, Y, and Z, but she still warrants a referral for discussion because she has hematoproteinuria. Number 4 is quite similar to number 1 if you're paying attention. So you've got an 85-year-old male. He's not quite as frail. He's got obstructive uropathy, hypertension, arthritis, and he's got an eGFR of 26. He's got BPH. He's got stable CKD. It's been there for ages. It's got amazingly similar eGFR and a fantastic blood pressure. I've never had so many patients with such good blood pressure. And he's not much exciting, and all these arthritis patients are on non-steroidals, I know, but it made it more simple for this if they weren't. So what are you going to do? You're going to do an ACR. And he's got blood and protein. And he's got an ACR of 80. Do you scan his renal tract? Well, you don't need to, but if we scan his renal tract to take it out of the way, then he's not got any obstruction. So he's got a KFRE of 18.9%, and he's got blood and protein in his urine. So in theory, you refer him, and this is kind of the but. I didn't mention it's a catheter sample, and actually, if your notes are anything like ours, it's not always clear immediately that it is a catheter sample, and the patient doesn't tell you, and you only find out a couple of weeks later. So the ACR is hard to interpret, and the figures are otherwise the same as the first case, and in the first case, he's got an ACR of 3.1%, KFRE of 3.1%. Having said that, we fully appreciate that in primary care, it's not really your job to work out, is this a significant ACR? Do I need to refer? The KRF says 18%, but actually the nephrologist is saying no. And we're quite happy for you to kind of ask us that. But if they have no other reason for having proteinuria, they've got a bit of protein in the urine, they've got a catheter, or if they've got a sterile pyuria, actually think, is it real? There was only 4 cases to give you time to ask any questions. Does anybody want to ask anything?
The role for proteinuria.
Mm-hmm.
So as GPs, if the patient's on a maximum tolerated ACE and we don't think they need to be referred and the proteinuria is still there, do we start an SGLT2 now?
Yeah, we'd strongly encourage you to start it. We have tended to start dapagliflozin 10 milligrams daily because you don't need to titrate it, but we'd strongly encourage you to start one. The only thing I'd mention is the recommendation is you check the renal function every 3 months if they're on a angiotensin blockade and SGLT2 inhibitor. And those of you who've sent advice and guidance and are probably getting a lot now of us saying, start an SGLT2I, keep an eye on it, and refer if it doesn't improve.
So what do we do practically with people with catheters then? Do we just not do protein urine?
It's a really good question. I've started intermittently doing a baseline, so I get one. I don't think that helps at all. I think I'd be inclined to go by the trajectory of decline of the renal function. I don't think I would routinely do an ACR, but I think that's probably my opinion. I don't know what you do, Will.
Well, I think, you certainly wouldn't feed it through a KFRE because the KFRE is only validated on a typical. I mean, in theory, it's meant to be an early morning urine, as you know. So I certainly wouldn't through an equation. But I mean, I think it would depend, wouldn't it? If you had a patient with gross edema and a serum albumin of 26, and you think, well, they could be nephrotic, then I would still measure. I know that I'm thinking like a nephrologist there, but for the great majority of people with catheter urines, there's not a lot of added value by sending it for an ACR actually. And even if you do, I wouldn't feed it through the KFRE.
So the follow-on question then is the decline in eGFR and what is a concerning level year on year?
Yeah, so I think I guess I should know what. So that criterion is still in the NICE criteria. It's still there, and it's actually quite a low level of GFR decline that they're recommending referral of 10. But you and I, everyone in the room knows that you could measure. Someone could have a steak dinner the night before and get an eGFR change of 10. So I think it again. It needs a bit of clinical sense checking. It's a bit like doing an Arden check for people that are suitable for total dietary replacement, isn't it? It will throw up some rubbish. So I still think it needs a little bit of sense checking. And I think, that apart from these people with CAS and what have you, the KFRE, I think, becomes quite helpful because, on the whole, the case Shareen presented with quite heavy proteinuria and quite rapid progression, almost everyone with heavy proteinuria, true heavy proteinuria, has rapid progression, actually. So by using KFRE, you will identify them as needing referral before you'll ever identify the delta GFR. Does that make sense?
This is like the PSAs or people who catheterise question that urologists get. Catheters cause a lot of problems.
Yeah, they do. I think that, coming back to the SGLT2I point, I think the NICE, I'm not a great fan of everything NICE do, but I think the NICE guidance on dapagliflozin for CKD is pretty crystal clear now on who should and shouldn't get it. And it's anyone, it's a GFR 25 to 75 and proteinuria of above 22.5 ACR in non-diabetic disease. Obviously, diabetics, it's anyone with proteinuria of any level. But that's an awful lot of patients with non-diabetic kidney disease and that's why people like the Northern Alliance are developing these dashboards, because there is actually a new therapy, or it's not that new a therapy, but a therapy that is being newly widely applied in chronic kidney disease that has a big proven potential to delay progression of the chronic kidney disease and to reduce cardiovascular events, as it does in all these other indications, and reduce heart failure admissions and all that kind of stuff. So I think one of the reasons for advocating case-finding type work and identifying who's at risk is that SGLT2Is are not as widely used in CKD yet as they might be. Mind you, neither are ACEs and ARBs, but that's a battle for another day. The threshold for stopping an ACE and an ARB for potassium is pretty low, I think. And there are an awful lot of people coming off ACEs and ARBs when they would still get a lot of benefit from them. That is personal opinion.
No, so you're right, he is anemic. The target hemoglobin we aim for in CKD 4 and 5 is a hemoglobin of between 100 and 120, so we wouldn't tend to treat. But I guess that's what I mean by I'm not remotely expecting you to remember the target hemoglobin for a patient with CKD 4 or 5, so it's entirely reasonable to say, he looks anemic, do you want to see him? If you remember it, great, but I'm not sure I would with everything else you have to remember. There's no other questions, will let you escape?
Well, no, I think there's more to come.
No from us.
Thanks very much, and thanks very much for the invite to speak to you.